Welcome from CVI2017. I'm Dr. Michael Luna here with Dr. Sahara Ismail from Emory. She'll be presenting hop, skip, and a stent, overcoming peripheral disease in high-risk PCI. Welcome.
All right, thank you for having me. So we're going to present a case from our VA. We have a 64-year-old gentleman with a history of coronary artery disease, CKD, hypertension, hyperlipidemia, and insulin-dependent diabetes, who was referred for an outpatient left heart cath for worsening angina. He had a left heart cath back in 2004, which showed some disease in the distal left main as well as LAD. He had significant disease in the MOM, as well as a subtotal occlusion in the mid-RCA. Most recent echo, he had an EF of 30 to 40% with some posterior wall kinesis and moderate MR. In terms of medications, he was pretty optimized. He was on a beta blocker, long-acting nitrate, and ranolazine. He was also on high-intensity statin, ACE, and low-dose aspirin. In terms of labs on a presentation, his creatinine was at baseline, 1.57. His troponin was 0.05, and his BNP was high at 421. And this is the left heart cath at that time, which showed he had pretty significant left main lesion with 50 to 60%. Oh, I'm sorry. As well as a 90% left circ lesion. His right showed that he had that CTO that we saw back in 2004. So the patient was referred to CT surgery for bypass. Unfortunately, after the left heart cath, he became hypoxic. Workup showed that he had aspiration pneumonia. He was intubated for a few days. He received a full course of the antibiotics. And then while he was sitting on the floor waiting to go to the OR, he had VFib cardiac arrest and then was taken urgently to the cath lab. His EKG showed that didn't really show significant ST changes. His troponin was 0.38 and his creatinine was at baseline. So we initially were trying to do a right radial approach. He had a lot of edema in the right arm, and there was a lot of attempts to put in an A-line, so we couldn't really access the right arm. Left arm had persistently lower blood pressures than the right arm, so we were worried about left subclavian stenosis. We went for the left, but we couldn't pass the wire, left femoral. So then we went to the right, and we shot the right, and we saw that he had pretty significant disease in his left common iliac and right external iliac. So a platinum plus 0.018 wire was advanced, and we used a 7x20 balloon. Following that, we then performed, We performed serial dilatation over an implant extra stiff 0.035 wire, and a 14 French sheath was inserted, and then we put the Impella CP. On angiography, he had a new occlusion of the OM and left circ, which was thought to be the cause of his cardiac arrest. We then, with a 7 French JL 3.5 guide catheter, we engaged the left main, and then we used a choice PTES to cross the OM lesion. We then did multiple dilatations with a Sprinter balloon 2.5x20. We then tried to pass a 2.5 by 38 Promis stent, but we couldn't pass it at the OM and left circ bifurcation because of severe calcifications. So then we took the guide liner further down the left circ into the proximal left circ to kind of provide us with some more support. And then we did some further dilatation with an NC Sprinter as well, and then we went back in with a Promis 2.5x20. We were able to stent from right at the tip of the OM distally, and then we took another stent as well, 2.75x8 proximally. We did a run-through guide wire, was inserted into the LAD, and he had pretty significant disease here. We're looking at an IVUS of the LAD with an area of 4 millimeters square. We also did IVUS of the prox left circ, and he had pretty significant disease of the left circ, so we also put in a stent 2.75x8 as well on the prox left circ. We then used the angioscope balloon, was inserted over the LAD wire into the left main in the LAD. And we ballooned it a few times and put in a 3.5x20 Promis stent. We post-dilated with an NC Sprinter balloon, and then we also put in a whisper wire down the left circ, followed by an NC Trek balloon, and we ballooned them simultaneously according to the kissing balloon technique. And then these are our results. So another view. And then we did IVUS, the left main afterwards. There was some malposition, so we did some further ballooning as well. And the patient did pretty well.
Very good. And when you're going to do this sort of intervention, do you have any consideration for doing angiograms from up above of the subclavian and the nominate arteries, just to get the lay of the land in case something goes awry when you're doing the intervention in the iliac and you're unable to support the patient through there?
Yeah, that's a good point, and it would have been a good thing to do in this patient as well. I think, by the time we were, we had the impella in and we were proceeding with the case, it was, about over an hour into the case, and the patient was hypotensive. So at that point, we were just trying to get in there and fix it. But that's a very good point.
And as you're explanting the impella device, I'm assuming you explanted this at the time after the intervention. Is there any consideration for performing angiogram of the iliac that you just intervene on to see if you have to implant a stent at that point, or just leave it be?
So at the time, we left it be. I think it was more because the patient had CKD and got a ton of contrast. But again, it's patient dependent. Yeah.
Great. All right. Thank you so much.
Thank you.
Here we wanted to show that the ISR, that the wire was truly in the subintimal space rather than through the stent, and we showed the stent, the strength was in the true lumen, but the IVUS catheter was in the subintimal space. So that's what we wanted to show here, but we don't routinely use it.
Perfect. Well, great case. Thank you for showing that to us.
Thank you.